All right, good morning, everybody. Happy Thursday and welcome to St. Joseph Healthcare Hamilton Medical Grand Rounds. I'll bring up the next slide and on to the next one. So we'll start off acknowledging the land on which St. Joseph Healthcare Hamilton sits, which is on the traditional territories of the Mississaugas and the Haudenosaunee Nations, and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So I'm delighted for this morning to have two of my hematology and thrombosis colleagues here with me, one of whom is presenting, Dr. Siraj Mithoowani, and the other is Dr. Rick Ikasaka, who is our hematology and thrombosis head of service here at St. Joe's. So I'll hand this over to Dr. Ikasaka so he can do a formal introduction for Dr. Mithoowani.
Thank you, Dr. Hafsek. So it's my great pleasure to introduce Dr. Siraj Mithoowani, who we know each other very well, and we'll be presenting our St. Joe's Medical Grand Rounds today on 5 things every internist should know about anticoagulants. Dr. Mithoowani is a clinical hematologist here at St. Joseph's Healthcare Hamilton, who specializes in benign hematology and venous thromboembolism. He obtained his MD degree and internal medicine and hematology residency, as well as clinical research fellowship in benign hematology and thromboembolism here at McMaster University. He became a full-time faculty member in the Department of Medicine in July of 2020. And his clinical and research interests are in venous thromboembolism, immune thrombocytopenia, and in health professional education. And without further ado, I turn it over to him for his rounds this morning.
Thanks, Rick. Thanks very much for that kind introduction. So I have no relevant conflicts of interest to declare for this talk. The objectives of this talk are a little bit ambitious. I was joking with Madeline, Dr. Verhofstadt before the presentation that these are not the only 5 things an internist should know about anticoagulants, but it's 5 things that I think that everyone should know across the board. And hopefully you'll get some insight as to the sort of typical things that we see in the thrombosis service and where we contribute to the care and where basically we can improve anticoagulant care for our patients. So by the end of this talk, you should be able to select an appropriate anticoagulant drug based on treatment indication and patient characteristics, describe ways to minimize the risk of bleeding on anticoagulant therapy, and describe some of the indications and risks for thrombolysis for acute PE. So the question is, why give this talk and why now? So I think we all recognize that anticoagulants are very high-risk medications, and they're formally defined as such by the Institute of Safe Medicine Practices. When we prescribe an anticoagulant, we basically have a very delicate balance between exposing our patients to a risk of recurrent thrombosis versus bleeding. And the case fatality rate of major bleeding is surprisingly high, around 8 to 15%. We're seeing more and more patients on anticoagulant therapy. This is from a study in 2013. I'm sure the number is higher now. At the time, there was over 350,000 Canadians that had atrial fibrillation, many of whom require anticoagulants for stroke prevention. And the incidence of VTE is also reasonably high, around 1 to 2 per 1,000 persons per year, and rises as we age. There's expanding indications for anticoagulant therapy. They're not just for venous disease anymore. Based on the COMPASS study, we now use low-dose vascular Rivaroxaban 2.5 milligrams BID in a subset of patients with polyvascular atherosclerotic disease, which increases the number of patients on treatment even further. I firmly believe that anticoagulant stewardship, the responsible prescription and monitoring of anticoagulants, is really everyone's responsibility. It's not just the thrombosis service's responsibility, but it's really everyone's responsibility. And that's in internal medicine as well as in a number of other specialties. So we'll get started with this first kind of quote unquote lesson. And I think that prescribing a DOAC is not as easy as it sounds. So we'll illustrate this by case. So imagine you have an 82-year-old man who's newly diagnosed with atrial fibrillation. He has a history of a remote GI bleed. He has coronary artery disease with stents placed in 2020, peripheral vascular disease, poorly controlled hypertension, dyslipidemia, and arthritis. His medications include aspirin, rosuvastatin, hydrochlorothiazide, ramipril, and he takes Advil PRN. His examination reveals that he's hypertensive at 160/99. His heart rate is 105 beats per minute. His weight is 66 kilograms. Some basic lab work is available showing a hemoglobin of 105. His MCB is 90, platelets 390, and his creatinine is elevated at 120, which gives him a creatinine clearance of 37 milliliters per minute, basically on the basis of his elderly age and low body weight. So the question is, what do you recommend for an anticoagulant in this gentleman? Your options are Rivaroxaban 20 milligrams daily, 2.5 milligrams BID plus aspirin 81 milligrams daily, or Edoxaban 30 milligrams daily or 15 milligrams daily, or Apixaban 2.5 milligrams BID. So just something to think about as we go through this next part of the presentation. I think we're all very familiar with the mechanism of DOACs, in 2022, but just to orient everybody, including our learners, we're talking about the factor Xa inhibitors. The ones that are commercially, available really are Apixaban, Edoxaban, and Rivaroxaban. And then we have one oral direct thrombin inhibitor, which is Dabigatran. So those are the drugs we'll be talking a little bit about today. Anticoagulant dosing is surprisingly complex. I think we take it for granted how complex the dosing regimens actually are. So the tricky thing is that there's a usual dose for all these drugs, and then there's numerous different reduced dose regimens depending on whether you're treating atrial fibrillation or VTE. And how you qualify, so to speak, for those reduced dose regimens depends not only on the indication for treatment, but on a number of other criteria that differ by individual drug. So Apixaban, as we all know, is prescribed at a dose of 5 milligrams BID, but the reduced dose is 2.5 milligrams BID, and that reduced dose is given if 2 of the 3 criteria are present. These are like the ABC criteria: elderly age, low body weight, and a high creatinine. A couple things about Apixaban is that, and this is pretty much true across all the DOACs and atrial fibrillation, is that patients with creatinine clearances between 25 to 30 milliliters per minute were all excluded from those really seminal trials of these drugs. Apixaban has some data to support its use in end-stage renal disease, but that's a little bit outside the outside the scope of today's talk, so we won't get into the details. And it's a substrate of PGP and CYP3A4. So the factor Xa inhibitors, Apixaban and Rivaroxaban, are PGP and CYP3A4 substrates, and Edoxaban and Dabigatran are just substrates of PGP. Rivaroxaban, as I'm sure we're all aware of, the usual dose is 20 milligrams daily. A reduced dose for atrial fibrillation is 15 milligrams daily. The only dose reduction criteria in atrial fibrillation really has to do with the creatinine clearance. That's the most relevant one, at least. If your creatinine clearance is somewhere below 50 milliliters per minute, you would qualify for the reduced dose. Again, creatinine clearance less than 30 was excluded from Rocket AF. The 15 and 20 milligram tablets, very importantly, need to be taken with food to maximize their oral bioavailability. And Edoxaban, which I think is the drug that we're probably maybe least familiar with because we haven't been using it for as long, at least in Hamilton, is dosed at 60 milligrams daily or 30 milligrams daily as a reduced dose. There is also a 15 milligram daily reduced dose that might be indicated in very specific circumstances. This is kind of a hybrid between the two drugs. The indications for dose reduction, you just need to meet any one of the following 3 criteria: creatinine clearance less than 50, weight less than 60 kilograms, or the patient's on a potent PGP inhibitor. Examples of that were studied in a clinical trial were verapamil, quinidine, and dronedarone. Interestingly, Edoxaban should be avoided when the creatinine clearance is above 95 milliliters per minute. These basically super clearers of Edoxaban are at increased risk of stroke compared to Warfarin. And you could consider a 15 milligram daily dose in very specific circumstances based on a study called ElderCare AF that randomized patients who are above 80 and at high risk of bleeding to either Edoxaban 15 milligrams daily or placebo. Dabigatran, which is the least commonly prescribed of these DOACs, is given at 2 conventional doses, either 150 milligrams BID or more commonly 110 milligrams BID. The dose reduction criteria are noted there. couple interesting things about Dabigatran that you're probably aware of. Number one, you shouldn't crush the tablets because that increases the anticoagulant exposure by about 2-fold. The drug should be stored in its original packaging up until the moment that the patient actually takes the medication, because the tablets are quite susceptible to the effect of light and moisture. These tablets or the drug often causes dyspepsia, so co-prescription with PPI is quite common. And again, this drug in particular should be avoided in patients who have a creatinine clearance less than 30 milliliters per minute. You'll see the lower limit for the other drugs here, at least per the monograph in Canada, is 15 milliliters per minute based on some observational data supporting safety in that 15 to 30 milliliter per minute window. Now for VTE treatment, it's totally different dosing. So for Dabigatran, if you're going to be using that for VTE treatment, you need a low molecular weight heparin lead-in with 5 days, and then use the higher of the 2 doses, 150 milligrams BID. For Rivaroxaban, there's a 21-day leading or loading dose of anticoagulant followed by 20 milligrams daily. And then per the results of a study called Einstein Choice, you could consider reducing the dose to 10 milligrams daily after 6 months. For Apixaban, there's a very, very potent loading dose of 10 milligrams BID for a week, followed by 5 milligrams BID. And then again, you could dose reduce at 6 months based on a study called Amplify Extension. And then for Idarucizumab, similar to Dabigatran, one key point is that it requires a 5-day lead-in with low molecular weight heparin, as that's how it was studied in the Hockey-side VTE study. Keep in mind that the dose reduction criteria for atrial fibrillation do not apply to VTE. And the creatinine clearance of 30 milliliters per minute is usually the threshold for using a DOAC in VTE. That 15 milliliter per minute threshold for atrial fibrillation here doesn't really apply. Just something to keep in mind. The thing that we see in practice, and that there's many publications about, is inappropriate DOAC dose reduction. In the Aristotle trial looking at the use of Apixaban in atrial fibrillation, only 5% of the patients actually received the 2.5 milligram BID dose. But I think we can all know anecdotally that that dose is far more common in clinical practice. Many more than 5% of patients in our clinical practice are receiving the lower dose of Apixaban. The problem is that nearly 60% of reduced dose DOAC prescriptions don't adhere to the best available evidence. And 20 to 30% of older adults in different cohort studies are prescribed an inappropriate dose. The reason why that's important is that you get exposed to a lot of the harm of the anticoagulant with the reduced dose, but you don't derive all the benefit. So folks, patients who are prescribed the lower dose inappropriately are at higher risk of thromboembolism in observational studies compared to the conventional dose, but they're actually at a comparable risk of major bleeding. So this is something we're very cautious about in our service, is the inappropriate dose reduction of these drugs. The other thing that's very common, it's essential really for me to talk about during this presentation because it's so common, is co-prescription of anticoagulants with aspirin or NSAIDs. Up to 30% of patients on DOACs take aspirin without a clear indication. Some of those indications are listed below. There are some other more unusual indications. This is the most important, sounds obvious when you say it, but it's the most important drug interaction with DOACs. And co-prescription with aspirin is associated with a comparable risk of thromboembolism in most patient populations, a 2 to 3-fold increased risk of any bleeding, and a 1.5-fold higher risk of hospitalization. So I think we often as clinicians underestimate the potency of the combination of an oral anticoagulant and aspirin. Just something to pay attention to, especially for patients who, obviously take a very detailed drug history, but being very conscious and cautious about the co-prescription of aspirin with DOACs would go a long way. The other thing about DOACs is that although we don't need to monitor the INR like we do with Warfarin, they're not really set it and forget it drugs. The follow-up for care for patients with DOACs is actually really, really important, and it encompasses a lot of different aspects. This checklist is adapted from an expert opinion that was published by Jim Duquetis and leaders of other national thrombosis societies. It's also available on the Thrombosis Canada website, but I really like it. It's basically another like A, B, C, D, E, F algorithm, starting with, this is a follow-up care in what we do in the clinic when we're following patients on oral anticoagulants or on DOACs in particular. The first is we ask about adherence and in a non-judgmental way ask about any missed doses. We review any special instructions that pertain to the drug, especially, for example, with Rivaroxaban, taking the 15 or 20 milligram tablets of food. Bleeding risk is dynamic, and we assess it at every clinic visit. So we ask about historical or current bleeding. We ask patients to minimize their alcohol use while on these drugs. We think about uncontrolled hypertension or falls risk. The usual recommendation is to measure creatinine every 6 to 12 months or more frequently in patients who are at risk of renal disease. We assess any potential drug-drug interactions, the most important of which is probably the combination of a DOAC and aspirin or an NSAID. But there are some other relevant drug-drug interactions. I mean, drug-drug interactions can be overcalled, and the clinical significance of many of them is unknown. But some of them we're very cautious about. Those are the ones that reduce the DOAC drug levels significantly. So those are drugs that are strong inducers, typically of PGP and CYP3A4. And the most common of which I've highlighted here, the ones that I look for in particular are these three anti-epileptics: phenytoin, carbamazepine, phenobarbital, rifampin, less commonly used, and St. John's wort. And in those cases, we typically avoid the co-prescription of a DOAC with these drugs, because there are actually some data showing that the DOAC drug levels go basically to undetectable ranges, and there have been adverse events associated with this combination, including in Hamilton. The examination really focuses on patients' blood pressure and their frailty. And then we think about a final assessment that incorporates the patient's values, and we reconsider whether the benefits still outweigh the risks of anticoagulation. Typically, it will in patients who have atrial fibrillation, like they will have a continued indication for anticoagulation. But for patients who are on secondary thromboprophylaxis for VTE, the risk-benefit ratio of indefinite anticoagulation, it's a little bit uncertain in many patients. So for those patients who have an excess bleeding risk, it may be a time to consider stopping the drug. And then we think, of course, about dosing. DOACs are not always the be-all end-all of anticoagulants in the outpatient setting. They have a number of contraindications. I'm sure you're well aware that DOAC should not be used in patients with mechanical heart valves based on the REALIGN study that randomized patients to Dabigatran versus Warfarin after mechanical valve insertion and showed an increased risk of thromboembolism and bleeding in the Dabigatran arm. They're contraindicated in pregnancy and breastfeeding and in child PUB and C liver failure, with the exception of Apixaban, which can be used with caution in patients with child PUB liver failure. I put end-stage renal disease here. Most anticoagulants at a therapeutic dose are, we would not recommend their use in end-stage renal disease, but there are some evolving data about the use of Apixaban in this setting, which again, we're not going to really get into the details here. And valvular atrial fibrillation, because those patients were not included in those seminal trials, but there's some observational data supporting the safety and efficacy of DOACs in those patients. They should, at least for all intents and purposes, are either contraindicated or should be used with extreme caution. Other times when I think twice about using a DOAC is when we're treating unusual site thrombosis. Again, we extrapolate a lot of the evidence that we have to this group, and this would be things like cerebral venous sinus thrombosis, splanchnic vein thrombosis, where we have a lot of experience using the combination of low molecular weight heparin and warfarin, and evolving experience with DOACs. LV thrombus, it's the standard of care, I would say, would still be warfarin, but some people do use DOACs. High risk, which would be triple positive, typically antiphospholipid syndrome. In those patients, DOACs have been associated with an excess risk of arterial thromboembolism, particularly stroke. And in some cancer-associated VTE, for example, upper GI malignancies, we would be cautious about the use. If we are not confident that the patient will absorb the DOAC appropriately, for example, if they've had a Roux-en-Y gastric bypass or a duodenal switch surgery, then we would either measure drug levels or avoid the prescription. And then we think a little bit about affordability, especially for patients who are using DOACs for extended thromboprophylaxis, secondary prophylaxis for VTE, because our limited use codes only last 6 months in that setting. So we'll go back to this case of this 82-year-old man with atrial fibrillation. The first thing I would do here is get rid of his aspirin because he has coronary disease and peripheral vascular disease, but his stenting was done in 2020. And there are 2 randomized trials that support the discontinuation of aspirin in this setting. Once if patients require anticoagulation for atrial fibrillation. So I would get rid of the aspirin here. I would get rid of the ibuprofen or minimize its use and add a PPI. One could also consider substituting it for a COX-2 selective NSAID or replacing it with Tylenol preferably. We would address his poorly controlled hypertension. He might need additional medical management for his hypertension because that is a modifiable risk factor for intracranial hemorrhage. And then we would consider carefully which anticoagulant we'd use and the dose based on his creatinine clearance of 37 milliliters per minute. So this is one of the few times I think purposely made the answer not Apixaban 2.5 milligrams BID, because I think people gravitate to that low dose of Apixaban. He doesn't strictly meet the dose reduction criteria for Apixaban, but he does meet it for Edoxaban 30 milligrams daily. So that's what I would recommend, although one could consider that he would have probably been a patient that would have been eligible or randomized into the ElderCare AF trial, looking at Edoxaban 15 milligrams daily in very elderly patients with excess bleeding risks. So that's something that could be considered. Okay, so moving on this whirlwind tour, we'll talk a little bit about how to manage DOACs before and after surgery. So again, we'll start with a case. A 70-year-old man is scheduled for a VATS left upper lobe resection for suspected lung cancer. He has atrial fibrillation with a CHAD score of 2. He's on Dabigatran 110 BID, metformin, candesartan, and amlodipine. His exam is essentially benign. His weight is 69 kilograms. His creatinine is elevated at 135, which gives him a creatinine clearance of 44 milliliters per minute. So what do you recommend before the procedure? Skip Dabigatran on the day of the procedure, skip 2 doses, 4 doses, or 8 doses. So we'll talk a bit about what we would recommend. So the challenge with periprocedural anticoagulation is that it's a very high risk period for patients. When we interrupt DOACs, we expose patients to a risk of thromboembolism, and if we let the DOAC continue in the periprocedural period, they are at risk of bleeding. There's limited data for what to do with anticoagulants outside of atrial fibrillation. So there are other patient populations like those with VTE where there's less data. Surgeries are very heterogeneous, as well as the operator's experience with different procedures. So the bleeding risk varies by operator as well as by surgery. And as internists, we're not aware necessarily of what all these different surgeries look like and what their bleeding risk is. There's a lot of clinical practice variability, at least in my own anecdotal experience. I find that internal medicine and thrombosis often think in the same vein, but our recommendations sometimes differ from a surgeon or an anesthetist. The first question I would ask myself is, does anticoagulation really need to be interrupted? So there are selected procedures that could be done on therapeutic anticoagulation, and I've listed some here. Minor dental work can be done on anticoagulation. Selected procedures with small bore needles like a thoracentesis or paracentesis, depending on the operator's comfort. Often we would skip a dose prior to those or a day or prior to those procedures, but they could be done on anticoagulation. You could do a diagnostic EGD and colonoscopy, for example, without a biopsy or polypectomy on anticoagulation as well. There are, this is only a small list, an abbreviated list. There are others. You could refer to the Thrombosis Canada Clinical Guide for your specific procedure you're interested in. The principles are that DOACs have a very short half-life, about between 8 to 12 hours, and so we only need to interrupt a few doses for the patients to be really off their anticoagulant entirely. The idea is to skip 4 or 5 half-lives of the drug prior to high bleed risk surgery to get them down to basically undetectable drug levels right before the procedure is done, or to skip 2 or 3 half-lives of the drug prior to low bleed risk surgery, accepting that there will be some residual anticoagulant effect, but not enough to influence the bleeding risk considerably. And then generally speaking, low molecular weight heparin bridging is not required in these cases. I think most of us are well aware of that in this audience. I think everybody should be familiar with this study, not least of which because it comes from our own internal medicine faculty and staff at St. Joe's, Jim Duquettis, and I think it's really just a very, very helpful paper. This is a study called PAUSE, which evaluated 3,000 patients on atrial fibrillation undergoing elective surgery who were taking Apixaban, Dabigatran, or Rivaroxaban. And in 23 centers, they tested out a standardized perioperative interruption and resumption schedule based on the DOAC pharmacokinetics. And they were looking at the safety of this algorithm. And in particular, they're looking at the rates of major bleeding, arterial thromboembolism, and secondarily, the proportion of patients with a DOAC level below 50 nanograms per milliliter at the time of a high bleed risk procedure. 50 nanograms per milliliter is considered, like, anecdotally really a very low or potentially clinically insignificant drug level. The pause algorithm is here, and this is a very helpful figure that's actually in the body of the paper. What it shows is this is the algorithm that we would be typically using, and this is the same algorithm that Thrombosis Canada that's on the clinical guide as well. I'll just walk you through it for a second. So on the left-hand side, you see different DOACs, Apixaban, Dabigatran, Rivaroxaban. And essentially, for high bleed risk procedures, for most of the drugs, you skip 2 days, two days of the drug. So there'd be no drug given on day -1 and day -2, for example, if you're on Apixaban and you're undergoing a high bleed risk procedure. If it's a low bleed risk procedure, you only need to skip one day of the DOAC pre-procedurally. The only tricky thing here is that Dabigatran is listed here twice, and that's because the recommendations differ depending on whether your creatinine clearance is above 50 milliliters per minute or below 50 milliliters per minute. So above 50 milliliters per minute, you treat Dabigatran like any of the other factor Xa inhibitors, but below 50 milliliters per minute, you double the duration of anticoagulant therapy. So if you have a high bleed risk procedure and you're taking Dabigatran with a creatinine clearance below 50, you would skip 4 doses of the drug, which would be actually 8 doses of Dabigatran prior to the day of the procedure, which we would call day 0. You resume the drug on post-op day number 1 for low bleeding risk procedures, assuming normal hemostasis, and typically we would resume a DOAC at a therapeutic dose on post-op day 2 or post-op day 3 for high bleeding risk procedures, again, assuming normal hemostasis. This is just again, a very abbreviated list of high bleeding risk versus low bleeding risk surgeries. You could refer to any of the references in the bottom right corner if you want more details. But I just want to point out that some things that are high bleeding risks that many people, I think, maybe don't necessarily consider, or they don't, at least I didn't think about as high bleeding risk before I looked into these lists, is sphincterotomy for people who are undergoing ERCP, or polypectomy in patients undergoing colonoscopy. But really any major OR greater than 45 minutes would be considered a high bleed risk surgery. Low bleed risk surgery, the selected list is here. The specifics of the procedure really do matter, but this is just a general list of low bleed risk procedures that would apply to that algorithm. The pause algorithm showed that basically this strategy was quite effective. So in terms of major bleeding, they pre-specified that this algorithm would lead to a less than 2% risk of major bleeding, like the upper end of the confidence interval would be less than 2%. The study met that endpoint for several of the DOACs, but you could see percentage-wise, the rate of major bleeding was clearly very small, somewhere between 1 and 3%. And the rate of arterial thromboembolism was very, very small, somewhere between 0.2 to 0.6% with this algorithm. Among high bleeding risk surgeries, there were a large proportion of patients who had DOAC drug levels measured at the time of the procedure, and 99% of them had a DOAC level less than 50 nanograms per milliliter. So it supports that that the drug really had washed out of the system before the surgery was done. Go back to this case, just remember it's a 70-year-old man who's undergoing a high bleed risk procedure. He's on Dabigatran, and his creatinine clearance is less than 50 milliliters per minute. So based on the pause algorithm and the Thrombosis Canada clinical guide, we would recommend skipping 8 doses of Dabigatran, or we'd be giving the last dose on day -5. Post-operatively, what we would typically recommend is VTE prophylaxis on post-op day 1, and then we'd resume the DOAC on post-op day 2 or 3, assuming that the patient has an epidural catheter which has been removed and surgical chest tubes have been removed as well. Just another plug for the Thrombosis Canada clinical app, because these are things that we, there's an algorithm, and so it's really great for a point of care resource. And this picture is a little bit dated. I don't even think, seems like a phone that existed in the early 90s or something. But yeah, thromboscanner.ca, or just navigate and get the app for iPhone or Android. It's a very helpful resource, especially for people who deal with these problems infrequently. So my next part of this presentation is how to manage bleeding on oral anticoagulant therapy, or really when, and more importantly, when not to use anticoagulant reversal drugs. So what's the problem here? Despite our best efforts, major bleeding still occurs in about 2 to 4% of oral patients on oral anticoagulants per year. The case fatality rate, as I mentioned earlier, for major bleeding is surprisingly high, around 8 to 15%, even in the DOAC era. And an intracranial hemorrhage has a case fatality rate of 50%. So although that's less common with DOACs, it's still very important. The other important thing is, it's just being recognized more, is that when you have major bleeding on an oral anticoagulant, a cascade of other problems arises. And in many of those patients, oral anticoagulants are discontinued permanently, which exposes them to a risk of thromboembolism. I'd like to convince you that an ounce of prevention is worth a pound of cure. So again, that's about anticoagulant stewardship. But what do you do when patients have bleeding on these drugs? We'll touch for 2 seconds on warfarin reversal. There's many publications. But basically, the principle for warfarin reversal is that for minor bleeding, you could generally continue the warfarin throughout, and the reversal is not required. If your INR is supratherapeutic, you could typically skip a couple of days of warfarin, or give a very tiny dose of vitamin K. For clinically relevant bleeding, which is kind of like the bleeding that would lead to an unscheduled physician visit, if the INR is above 1.5, we would withhold the VKA, and we'd give, again, a small dose of vitamin K and recheck the INR. For major bleeding, which is really what I want to talk about, if your INR is above 1.5, the key is to do your usual management for bleeding, which would be like compression and whatever surgical procedures you need to do, local measures, transfusion and resuscitation. But you would give a large dose of intravenous vitamin K, as well as 4-factor PCC based on the INR and the body weight. We rarely give PCC a second time. It may be indicated in some circumstances. Sometimes patients need additional vitamin K. The dosing for PCC depends, again, on, as I mentioned earlier, on INR and weight. And the top grid is from the Hamilton Health Sciences order set for PCC. It's what I typically use. It should be rounded to the nearest 500 units, and the dose range is between 500 units and 3,000 units. The bottom dosing table is from a Thrombosis Canada guide. So for Dabigatran, we now have a drug called Idarucizumab, which is available at St. Joe's and other hospitals in Hamilton. Idarucizumab, as you're probably aware, is a monoclonal antibody that's directed against Dabigatran, and is supplied as 2.5 gram vials, and in St. Joe's, and it's available through our hospital pharmacy. In the Reverse AD cohort study that enrolled 503 patients, there were 2 groups of patients, one that had acute bleeding, 301 patients, and another group that required urgent surgery on Dabigatran. Efficacy from biochemically was excellent. 100% of patients had reversal of a prolonged dilute thrombin time, which is our surrogate for Dabigatran drug levels, within 4 hours. And hemostasis, as judged by the treating clinicians, 68% of patients had bleeding cessation in 24 hours, and the time to hemostasis was 2.5 hours. All of these drugs have some safety risk, and that's partly because patients who have major bleeding are at risk of thromboembolism because of anticoagulant interruption. So in this cohort, there's a 5% risk of thromboembolism in 30 days and a 13% risk of mortality. For the factor Xa inhibitors, Apixaban, Rivaroxaban, and Idarucizumab, what we do in Hamilton is we give prothrombin complex concentrate, or Octaplex. There's not great data to support this practice. So we give an empiric 2,000 unit dose of PCC. This meta-analysis included studies up to September 2018, and only included 10 case series of 340 patients, and no randomized trials evaluating this practice. The efficacy based on these case series seems quite good. within their limitations. The proportion of patients with effective management of major bleeding ranged between 70 to 80%, depending on what definition of major bleeding was used in the studies. All-cause mortality was 16%, and the rate of thromboembolism with PCC for this indication was 4%. Although when I counsel patients about this, I typically quote the upper limit of 8% because that's where the upper end of the confidence interval lies. The certainty of evidence was very low for all these outcomes. So just keep that in mind, that PCC we have a lot of experience with it, but there's not a tremendous amount of evidence to support its efficacy and safety in this setting. The hottest item here really, and the newest kid on the block, is Andexanet. We don't have it, it's not accessible really across Canada, I think, certainly not at St. Joe's, but because we get asked about it often, I just put added a couple of slides about it. Andexanet is a factor 10A decoy molecule that was developed to reverse both direct and indirect factor 10A inhibitors. So that would be the DOACs as well as heparins and fondaparinux. It's a recombinant form of human factor 10A that binds competitively with factor 10A inhibitors. So in this diagram, this really big molecule you see is factor 10A, and this literally tiny red triangle is the factor 10A inhibitor. So Andexanet alpha, it mimics factor 10A, but it lacks the catalytic domain, so it doesn't really act as a clotting factor, and it lacks a membrane binding domain, so it can't attach itself to the platelet surface to initiate coagulation. It mops up the factor 10A inhibitor, which makes it unavailable to actually inhibit factor 10A. Andexanet is very expensive. The projected cost is $22,000 per patient in some one cost-effective analysis, compared to around $5,000 for four-factor PCC. In the Annexa-4 study, which is a study of 352 patients, another cohort study, and these patients had acute major bleeding on Apixaban, Rivaroxaban, Edoxaparin, or enoxaparin. The efficacy of Andexanet was shown. Biochemically, it led to a 92% reduction in anti-10A activity for baseline, and 82% of patients had good or excellent hemostasis at 12 hours. It did come at a cost, 10% risk of thromboembolism at 30 days and 14% risk of mortality in these patients. It's a really beautiful slide that was produced by Deb Siegel. This is a great resource, the bottom right corner, really nice reference if anyone wants to read further. But basically, the emphasis is really saying that managing bleeding is about more than anticoagulant reversal. That's just one piece of the puzzle. And if you look at this major bleeding arm, in folks who have non-life, limb, or organ-threatening bleeding, interrupting the DOAC is usually enough. But we would recommend general measures like compression volume, replacement, transfusion, support. For life, limb, or organ-threatening bleeding, we would interrupt the DOAC. And we would administer a reversal agent. Mark Crowther has texted me and said that AstraZeneca now owns Andexanet, and they might bring it to Canada, market to Canada within the next 18 months, but it's extraordinarily expensive. He states that the usual dose of Andexanet would be about 80,000 Canadian dollars. So it will be about 40 times more expensive than our other anticoagulant reversal drugs. PCC is about $2,000 per dose, so thank you, Mark. Anticoagulant reversal in practice, I would suggest that you just use a standardized procedure. These drugs need thrombosis approval. This QR code, if you scan it, will lead you to the anticoagulant reversal order set, like a direct download of it, which is a PDF, and it'll tell you how to dose PCC, Idarucizumab, and vitamin K for all these different types of scenarios. It's a very, very, very helpful guide. That's just useful to store on your phone. The second last thing I want to talk about is just a few slides on cancer-associated VT, just because it's such a common reason for referral to the thrombosis service. So we know that cancer patients have a 4 to 7-fold increased risk of VTE. The absolute risk of VTE in cancer is very high, around 8 to 10%, and it's the second leading cause of death in cancer patients after cancer progression. Before the DOAC era, the standard of care was low molecular weight heparin. This is a meta-analysis of randomized trials comparing low molecular weight heparin to vitamin K antagonists. And as you can see, low molecular weight heparin is associated with a lower risk of recurrent VTE at 6 months and a comparable risk of major bleeding compared to warfarin at 6 months. So it has a lot of benefits and doesn't have a lot of harm. And therefore it was a standard of care for many years. We now have 3 randomized trials looking at the use of DOACs in this population. Hockey-side VTE cancer for Edoxaban, the SELECTI pilot study for Rivaroxaban, and Caravaggio for Apixaban, which is the most recent study. I just want to lead it, talk just about 2 points on this slide. One is that if we're using Edoxaban, just like we would be doing for a regular dosing of VTE, it needs a 5-day lead-in with low molecular weight heparin, so it's not something that's given right off the bat. And for all of these DOACs, with the exception of Apixaban, they reduce the rate of recurrent VTE, but the cost is an increased risk of major bleeding. And that's in particular in folks who have GI malignancies. So I'll show that in the next slide. That wasn't shown in the Caravaggio study. There may be numerous reasons for that. But when we prescribe DOACs, we tend to consider patients, we tend to prescribe DOACs in patients who are a little bit at lower bleeding risk, and we tend to avoid their prescription, in particular in patients with upper GI malignancies or urothelial malignancies. This is from the Hockey-side VTE cancer study showing that the risk of major bleeding was much higher with Edoxaban if you had a GI cancer compared to dalteparin. Rate of major bleeding in the GI cancer in the Edoxaban group was about 13% compared to 4%. But in non-GI cancers, the curves overlap, so the drugs are equally safe. Again, excellent reference. It's my favorite algorithm and the one that I actually think about when I'm thinking about DOACs for cancer-associated VTE. It's a useful reference to review. If you have a patient that's at high risk of bleeding, and there's numerous risk factors documented here, we would typically favor the use of low molecular weight heparin. For certain cancer types, we would also favor the use of low molecular weight heparin, and that would be, there would be individualized decision making with the patient, but in particular active GI or urothelial tumors, we would consider a limited number of drug interactions based on a review as well, because the low molecular weight heparins don't have any relevant drug interactions, but there are some potentially relevant drug interactions with DOACs. And then we would typically follow the patients every 3 to 6 months and stop their DOAC once their cancer has been cured or is in remission. Okay, finally, just again, a few slides on when and how to prescribe systemic thrombolysis for acute PE. Again, very, very common, or not common, but scary call that internists might get. And this is where, we can provide some input, but it really is a shared decision between it's a multidisciplinary decision between different physicians as well as the patient. So firstly, I think it's probably best now to get away from the nomenclature of submassive versus massive PE. I think this is a much more specific way to risk stratify PE, and this is based on the European Society of Cardiology PE guidelines, this figure at least. So high risk PE, for the purposes of what I'm going to talk about next, is basically those patients with PE and hemodynamic instability. They also have RV dysfunction that's documented on a TTE or CTPA, and typically they have elevated cardiac troponin levels, although not always. Low risk PE is your kind of run-of-the-mill PE without hemodynamic instability, no RV dysfunction, and typically we would not even measure the troponin, but it would be negative if it was checked. I like this risk stratification because it subclassifies patients with intermediate risk PE to intermediate high and intermediate low. And it says intermediate high risk PE where you might consider thrombolysis in very select circumstances. So in those patients, they don't have hemodynamic instability, but they do have RV dysfunction on a CTPA or echocardiogram, and they have elevated cardiac troponin levels. So the cardiac troponin and the CTPA images or an echocardiogram are important for stratification purposes. So this is a relatively old study now. The PEITHO study is the largest randomized trial for thrombolysis in acute PE. And it looked at tenecteplase versus and heparin versus heparin alone in a group of patients with high intermediate risk PE. So these are normotensive patients with PE that have RV dysfunction as well as an elevated cardiac troponin. So this is 1,006 patients. I talk about the risks first because I think it's really important from a counseling point of view when we're talking to patients and their family members about the pros and cons of lysis in this setting. So the risk of major bleeding that I keep in the back of my mind is a 10 to 15% risk of major bleeding and a 2% risk of intracranial hemorrhage in this randomized trial. The risk of intracranial hemorrhage seems to be a lot higher in older individuals. And that was shown in a meta-analysis. The data is not shown here. The thing with the PEITHO results is that the primary outcome was composite of death from any cause and hemodynamic decompensation. You'll see that the primary outcome was there was 13 events in the tenecteplase group and 28 events in the placebo group, which was in favor of tenecteplase, but it was all powered by this hemodynamic decompensation. Death between these groups was not different. And you'll see that that a lot of patients in the placebo group eventually did get a thrombolytic drug. So the idea is that some of the patients in the placebo group decompensated and then got a thrombolytic drug once they declared themselves essentially as having a high-risk PE. So this data could be interpreted in a number of different ways, but I think many of us interpret it as saying that you could very, very closely monitor those patients with intermediate high-risk PE, and at a sign of decompensation, that may be a better opportunity to actually initiate thrombolysis. There really is no long-term benefit of thrombolysis. This cohort, a PEITHO cohort, was followed long-term, and it showed no difference in the rate of CTEPH or long-standing dyspnea, whether or not you received thrombolysis. And there's no echocardiographic differences in RV dysfunction or pulmonary hypertension between these two groups. The dosing of thrombolytics is really controversial. I would say that the conventional dose for alteplase, which is most commonly used, I think, in Hamilton, is 100 milligrams over 2 hours or 10 milligrams over 2 minutes, followed by 90 milligrams. But there is a reduced dose bolus regimen that can be considered and is in use in some hospitals in Hamilton more commonly. So the reduced dose bolus is 0.6 milligrams per kilogram up to a maximum of 50 milligrams, and it's given very quickly over 2 to 15 minutes. The reduced dose bolus it's only been evaluated, as far as I could gather, in 2 fairly small and methodologically limited randomized trials called MOPIT and China VTE group. We won't get into the details, but we're looking at randomized trials that enrolled around 100 patients. And the feeling is that the reduced dose thrombolytic is effective and it leads to less major bleeding, but it really is highly uncertain. There's no great comparison between these 2 different dosing regimens in VTE. Catheter-directed approaches are available at St. Joe's. We're fortunate to work at a center that has interventional radiology expertise. I would consider catheter-directed thrombolysis in patients at moderate or high risk of bleeding because there's a lower total dose of thrombolytic drug delivered. So that would be on the range of 8 to 24 milligrams of TPA versus 100 milligrams of TPA if we were to use a conventional dose. We could supplement the clot retrieval by a mechanical method. But there are some disadvantages. Number one is it needs an experienced operator and it's not always available. Time to catheter placement can be long compared to just administering a systemic thrombolytic. And just like any other invasive medical procedure, the protocols are really, really heterogeneous. And there's a lot of differences between operators in my own anecdotal experience. So for example, the type of the dose of lytic that's used, whether there's clot retrieval done, whether the length of the TPA infusion and the anticoagulation protocol post-TPA, it's not really that well standardized, at least in my own experience. There's limited clinical data showing the utility of this approach. There's only one randomized trial called Ultima that had a surrogate outcome just of hemodynamic parameters that showed the efficacy. Okay, so to summarize this whirlwind tour of anticoagulants, number one, or actually summarize first this talk about thrombolysis. First thing I would remember is that lysis is associated with 10 to 15% risk of major bleeding and 2% risk of ICH. For folks who have high risk PE, so those are clearly decompensating and have hemodynamic instability, we would thrombolyse those patients. If they're low bleed risk, I would typically recommend a systemic thrombolytic drug at a conventional dose. And if they're at moderate high bleed risk, I would consider a reduced dose thrombolytic or a catheter-directed approach. For intermediate high risk PE, so these are folks who have RV dysfunction and an elevated trope, but that are hemodynamically stable, it's really individualized. It's really challenging to make decisions in this group. Based on the PEITHO study results, I think We would typically observe closely for deterioration before proceeding with thrombolysis, but one could consider catheter-directed thrombolysis over systemic thrombolysis just to reduce the risk of bleeding in this group. And for intermediate low risk PE, of course, we would anticoagulate without thrombolysis. Again, there's an excellent order set. If you scan this QR code with your phone, you can download a PDF. This is from the Hamilton Health Sciences, but it just gives you the dosing regimens and gives you a flavor of the drugs that are used. So that may be a helpful resource for you. It's available on Citrix as well. So to summarize this talk, kind of whirlwind tour, as I was saying, number one, I hope I've convinced you that prescribing DOACs is not as easy as it sounds. They're not set it and forget it drugs, and dosing errors, particularly underdosing, is really common. We would encourage the use of a standardized algorithm to manage DOACs before and after surgical procedures. We would recommend using anticoagulant reversal drugs judiciously, and these are different options available in Hamilton right now. DOACs are very effective for cancer-associated VTE, but patient selection is critical because they seem to be associated with an increased risk of bleeding in some cancer types. And finally, thrombolysis is definitely indicated for high-risk PE with hemodynamic instability, but still remains controversial for intermediate high-risk PE. And again, patient selection is critical. So with that, I will stop talking and I would be happy to take questions. Thank you for your attention.
Thank you so much, Siraj. You said you were going to share with us 5 things that everybody needs to know, but I think there were at least 1,000 of pearls buried in there. We've got a couple of minutes for questions, and I see that there are some coming through already. So I'll just start with the questions in the Q&A, and to others, if you have other questions, if you'd like to add it into the Q&A, that would be great. So we have a question here. Should there be an interruption of oral anticoagulation in patients with an AKI, so acute kidney injury?
So what I would typically do is, I mean, that depends on the setting that you're in, but generally speaking, if your creatinine clearance falls below 30 milliliters per minute in folks who have VTE, or less than 15 milliliters per minute for patients who are on anticoagulants for atrial fibrillation, we would typically interrupt the anticoagulant while their kidneys recover. Many of those patients are inpatients, in which case they could be prescribed an alternate anticoagulant, for example, a low molecular weight heparin for VTE prophylaxis during that period of DOAC interruption.
Great, thank you. And before I get to the next question, there's a comment here from Dr. Duquetis, who you had referred to his work several times in the talk. Excellent presentation, Siraj, clear, concise, elegant.
Thanks,
so
Ken.
high accolades from
absolutely.
Our respected colleague there. So we've got another question. Is there good evidence of lowering DOAC doses in frail or low hemoglobin or falls risk patients? It happens so often, usually justified using above said reasons.
So that's a great question. So regarding falls, there are some modeling data that show that you need like hundreds of falls per year to justify stopping an oral anticoagulant solely on the basis of frequent falls. So individuals who have frequent falls are still good candidates for oral anticoagulant therapy if they otherwise meet the indications. Regarding the dose lowering, there's only one randomized trial that's really looked at frail elderly patients at high bleeding risk, and that was that Elder Care AF study. That's the only one that I'm aware of, at least. That looked at edoxaban 15 milligrams or placebo in very old patients above the age of 80, who the providers felt would basically that anticoagulation would. There was equipoise about prescribing anticoagulation at all for atrial fibrillation. And in that study, edoxaban 15 milligrams daily did reduce the risk of stroke and systemic embolism, but it did cost. They had a cost in terms of major bleeding. So you use that data with caution. But otherwise, I would stick to the drug monographs for the anticoagulant dosing, because underdosing is really, really common, and it also leads to harm.
Yeah. Excellent. So much that could be said there, and so much that can be individualized to the patient scenario, but such excellent guidance and such a common question that comes up. So there's one more question here from Dr. Catherine Clace. Excellent talk, Siraj, beautifully done. What do you recommend for people with stable GFR 15 to 30? and in the two scenarios, either VTE or atrial fibrillation?
So I'll answer the second question first, which is atrial fibrillation. So the drug monographs kind of quote unquote allow us to use the DOACs, the factor 10A inhibitors down to creatinine clearance of 15 to 30. So if they have a stable GFR between 15 and 30, I'd personally in atrial fibrillation be comfortable with prescribing a DOAC. And typically I would prescribe the one that's the least renally cleared, which would be Apixaban. There's some controversy as to whether you should use those ABC criteria there for the dose reduction. I think many of us, once the creatinine clearance drops below 30 milliliters per minute, would use the reduced dose of Apixaban, which would be 2.5 milligrams BID. And we would be checking the creatinine quite a bit more frequently than every 12 months, say, because in those patients, if their GFR drops significantly lower, then we would interrupt the DOAC or stop it altogether and use an alternate anticoagulant. For VTE, really, there's not a lot of data supporting the use of DOACs in patients who have a GFR below 30. So unlike the atrial fibrillation literature, there's no empiric dose reductions for a GFR less than 30. I will say that, between that 20 to 30 milliliter per minute range, many of us do use Apixaban because we still think it's probably better than the alternative, which is, Warfarin and low molecular weight heparins are also not an option, but they should really be used with extreme caution because there's not a lot of data to support that practice. And again, in patients who have a GFR less than 30, I think most people, myself included, would be using the least renally cleared drug, which is Apixaban, just from the biologic rationale.
Excellent. Thank you so much. And I'm seeing that you have answered everybody's questions and they're ready to go off and stomp out thrombotic disease. So thank you so much, Dr. Mithoowani. I also want to acknowledge that this was one of, if not the best attended St. Joseph's medical grand rounds of this academic year. So obviously when folks saw your topic and the presenter who was on tap, they made sure to block off their 8 to 9 a.m. this morning. And this will be recorded and available on the McMaster Department of Medicine YouTube channel also for anybody who didn't catch all of the info as it was flying by or wanted to rewatch, or for those who weren't able to attend. Thanks again so much, Siraj, for a beautiful presentation. And to everyone who's joined us this morning, thank you as well, and have a wonderful day.
Thanks so much, everyone, for your attendance. Thank you, Dr. Verhofstadt.